A very, very warm welcome to all of you. I'd say again that we would want to hear questions from you as much as possible, and even if we had to start slightly late, I hope we're able to accommodate that. But even if not, we like to gather questions for sure so we can come back to it. So the code is on the screen now, and please do log in and share your questions there. So to start off, I think health has been on our minds since the past 2 years. We cannot deny it. It's something that all of us have been thinking about no matter which field we were in. So in that sense, this panel is extremely important because we all know that some of the biggest decisions are taken, or the biggest innovations that happen are in time of crisis. So hopefully this session will offer us to also kind of reflect our public health system in general a little bit, not just from a COVID perspective, but in general. And as we kind of move forward, we really learn from the rich experience that is there on this panel and move forward from there. To start off, I would pass on the mic to Neeraj, and whichever way you prefer, sir. And
too many pages. Hi, good morning. Great to see all of you. And I'm really glad that I got invited. Thanks, Harish, wherever you are. And I remember when I got the invite and I read it, I said, yeah, I'd love this idea. Then he said, it said, it's in person. And I said, that's even better. And I said, absolutely, yes. And then as the list of people started coming in, I got a little worried. I've got my donor on the panel. I've got prospective donors out there. We have government in the room. I said, okay, now he wants me to confess in front of all these people about our failures. And so that was getting a little worrying. But having said that, I think I reached out to my teams. I said, okay, let's talk about where we failed. And I got lots of pages of information. Mostly it was about government failure. They kept talking about how government didn't do this and government didn't do that. I say, hang on. This is not about government failure. We know that there are challenges in the government, and that's why we have a job. Otherwise, we wouldn't have a job. But since we're talking about our failures, so let's talk about our failures. Having said that, I still got 9 pages for 8 minutes, so I'm going to try and rush through them. I think the challenge always is that we don't actually say what we really know, or what we actually know about our failures, or what we feel about our failures. And that's also because as a not-for-profit, and I think this was discussed yesterday also, funding is extremely important for us, partnership with government is extremely important for us. So we are constantly doing a peacock dance to make sure that everybody likes us and they believe that we can deliver. But having said that, there is a truth. It's a very competitive sector, and we normally talk about the truth only in closed rooms, unfortunately. Path has worked in innovation for 45 years, so vaccines, diagnostics, devices, and system innovation. So we are very, very used to failures. There are, out of 100 things that we do, 1 is a super hit, super success, 90 fail, and 9 are probably somewhere in the middle. So we do know what failure means very well. But I'll just jump straight to the topic that I want to talk about. Out of those lots of examples that came from my team, the one that really stood out for me was oxygen. Does everybody know there was an oxygen crisis in India during Delta wave? Can I see some hands here? Everybody, including people who lived in the Netherlands, right? So we all knew that there was a crisis of oxygen. And India responded. And I'm proud to say, in a way, that Path was right at the center of that response. At the peak of it, we had 400,000 new cases of COVID a day. We had 3,000 daily deaths also. And a lot of the challenge was an unavailability of oxygen. Path had been working in oxygen for many years, so we jumped in. Government started calling us. Our donors started calling us. Partners started calling us. People who we never talked to before started calling us. People who never worked in health started calling us, and everybody wanted to get into oxygen. Everybody wanted to support oxygen. Government was, of course, also trying to respond to the crisis. Some things worked very well. There was, instant response. By the way, this challenge of the peak lasted only for about 6 weeks. So that was immediate response for those 6 weeks was reallocating industrial oxygen to medical. Those kind of things work, transporting quickly from one place to the other, etc. But what also happened was huge amount of infrastructure got created, massive amount of infrastructure. We currently have about 4,000 oxygen plants. One plant costs about 1 crore of rupees. There are 4,000 oxygen plants now across India. Every district hospital has probably 2. Sub-district, we've got plants. There are plants lying all over the country. Most of them were functioning at some point or the other. We're very proud that those 4,000 plants went out there. Government was funding most of them. Donors were funding some. They also got operationalized, which was absolutely fantastic. So extremely proud. That's our sort of success. But the challenge is that today, as we stand here, about 80% of those plants are non-operational because there is no demand. You don't need that oxygen today. That was a crisis peak, and we've planned for that peak. We've got it. The other challenge is that when the next crisis hits, by that time, are these plants still going to be operational? Are they going to have maintenance? Are they going to have support which will actually continue to make them useful? Just to give you some numbers, I talked about the plants, but also oxygen concentrators. There were about almost 3 lakh oxygen concentrators, 300,000 oxygen concentrators that came into the country. They've been spread all over the place. I can tell you from my experience, from my team's experience on the ground, again, 80% of them have never come out of the box. Because by the time these oxygen concentrators started coming in, the peak crisis was over, and we were really now thinking about what to do with them. So where we are today is thinking about how do we deal with this immediate crisis, this impending crisis. How are we going to make sure that these things are going to be actually operational beyond COVID? Are we going to have this equipment available as and when the next crisis hits for our regular health system? A lot of it is not even being, concentrators are great things to have at a small sub-health center, but they aren't being used. They can be used for pneumonia, for heart diseases, etc., but they aren't being used. So that's really our challenge. The bigger challenge is nobody's interested. Nobody's interested. The government is not interested. Crisis is over. Let's get on with something else. Donors are not interested in funding any more of that work. The system is not interested in talking about oxygen. We have crossed that bridge, is the sort of feeling. Our years, 10,000 crores have gone into this asset, and we've been part of it. So really, when we think about our failure was to be able to actually predict this, to actually think about what we're going to do after the crisis is over. But at that point, there was just this frenzy of putting all this equipment there, getting these started, etc. And somewhere we missed the boat on sustainability. We missed the boat on how these assets could be really useful going forward for the health system. Quickly, I know that time is tight and we have started a little late. I just want to talk about a few others. So oxygen is the big one for me. But talking about other failures, we have programs where we've run in the low resource settings in Mumbai. We ran a hypertension management program. The government wanted support on implementation. The donor wanted to do an RCT. And we were sort of struggling in between that. And I don't think we did a great job of it. And that program actually didn't really work very well. The challenge also is to think about, when we go in, we think about a specific problem in a very narrow way. But we need to think about the economics. And a lot of times the economics don't work. There are social determinants, there are behaviors, human behavior, which we don't think about. We don't think about whether the system can actually manage it. Like the operation and maintenance of oxygen now, the system is all struggling with it. People actually shipped, our diaspora was great. I don't know how much money they pumped in during the oxygen crisis. They shipped concentrators to every district across the country. And now those assets can't be found mostly. What we need really is some amount of authenticity. We need to be able to go back. We need to think about what, what possibly can we do around sustainability? And I think we are blindsided about a lot of these issues when we go into a program. I mean, and I'm blaming myself because, we run a program. So we focus on donor, immediate requirement, government. But actually there is something much larger there. There is something much more comprehensive there which is going to build sustainability, which is going to bring long-term thinking around it. And I think we also think that, we are really important, but actually we aren't. We're very, very small in this whole larger system, especially when it comes to technical assistance. Just coming to some products, I just want to quickly end with a couple of products. We helped develop something called PharmaJet Tropis, which is a needle-free vaccine delivery system. We developed this great product, doesn't hurt when you get a vaccine or any kind of an injection. Not been very successful. It's been, the largest challenge has been cost. The product is too expensive. You've got to make a different kind of a vial if you want to put it into that. So vaccine companies need to be, okay to do that. There's fear around contamination because you're using the same thing again and again, although it comes through a jet spray, so actually there is no contamination, but that's the worry. And that's 10 years old, great product, hasn't worked. Another one which I want to quickly mention, and this is on women empowerment. We developed a women's condom. Fantastic. Moved the decision from the man to the woman. 10 years ago or 7, 8 years ago, this product came in. Has not been successful. It has just not been accepted. And two large issues, women just did not like the product. They did not, from a behavior perspective, they just didn't think that was good. And the second thing was it was expensive. And we haven't been able to bring the price down. We have another one which is actually just approved in the government system called Cyanopress, which came out also of the PATH system, which is an injectable contraceptive, self-injectable contraceptive, which can be used, which can keep you safe for about 3 months. And very good product, been around for many years now, but very, very small in its reach. So those are some of the examples that I wanted to just quickly bring. I think I am sort of running out of time. Just to close, I think it's important to have these conversations, and Harish, thank you for this. It's important to have them more regularly than once in 3 years, Harish. It's important to have them with the right stakeholders. They're all in the room today, so that's fantastic. Congratulations to you, Harish. I don't know what the repercussions are going to be for me after this, but that's fine, Harish. I'll take that as it comes. But we should have more of these conversations. I think, like I said, I have 9 pages which came from all my teams as we dug deeper. And there are a lot of things we actually learned through this process as we were preparing for this conversation. So thank you so much. Thanks.
Thank you so much, Neeraj, for not only just sharing your failures, but also just extending this experience to the team as well. So we hope PATH takes it forward from here on, continuing to reflect. Many points that I feel all of us could relate to. And again, I think the great thing about this is that you're talking from a health sector, but I could relate it in the energy sector. And I know many of you would be able to relate the same in livelihood. So thank you, Neeraj. The next thing, the next 2 speakers, I think when we speak about health, like a common metric that we all use is MMR and IMR. And I think that is something that we use to kind of check progress, look at success of the public health infrastructure, the main thing that we all kind of work towards, or many of us in the sector work towards. And our next 2 speakers are going to share some learnings on that. So first I'll request Rachna ji to please share her experience, and then we'll have Rajani ma'am. Whichever way you prefer, ma'am. We'll have your presentation, and you have a clicker, ma'am.
Good morning, a very good morning to all. And I would like to thank the SELCO Foundation for this invite, and I hope I do some justice to it. And whatever I am presenting, it's not that I am blaming the government. I am also a part of this system, and whatever experience I have for the last 23 years that I have been working, I have tried to just bring it together. I would like to start with a case scenario. A 22-year-old lady, Rani, who is an Adivasi woman who's pregnant for the first time. She has attended her 4 antenatal clinics at the local village health and nutrition day, and she goes to her neighboring health and wellness center, which is around 70 kilometers from the nearest hospital. She develops bleeding after delivery, which we also call as postpartum hemorrhage, and passes around 800 ml of blood. What do you think would happen to her? What will determine her survival? So this is what exactly I plan to discuss today. For myself, I would say I am an obstetrician and a gynecologist who has evolved and has been running a comprehensive primary healthcare center, and with a commitment towards the maternal well-being, maternal health being important. And this setup was situated in the rural parts of Chhattisgarh, and we have patients and women attending the clinics from more than 3,000 villages, which extend in the Adivasi belt of central India. But for now, present for the last 2 years, I am now working in the regional medical college in the Bilaspur in central India. So now working in these 2 different scenarios, where I first initially have worked in an NGO, and now because I am in a government setup and have also been a part of the rollout policy of the institutional delivery assurance paradigm, which was brought in because of the very high number of maternal deaths which were happening, and also deaths which are happening while women are trying to bring forth life into this world. So in the early 2000s, the maternal mortality rates were very high, and also because of some recommendations made by the WHO, we rolled out this program of the National Health Mission was started in around 2005, and this was followed by the Janani Suraksha Yojana, which were on its heels. And basically it was started with the aim of institutional delivery for all the pregnant women. We aiming for having institutional delivery for all the pregnant women. And one had to ensure it by having skilled manpower, good infrastructure, and adequate amount of supplies. And a conditional cash transfer of rupees 1,400 was also offered, along with free to and free transportation to the institutions. My organization, where I worked for the last 2 decades, was also a certified facility for this ambitious national program, I would say. So as this program started, the Janani Suraksha Yojana, obviously, surely the numbers of the hospital deliveries increased. It was merely 18% in the beginning in around 2005, and over the next 12 to 13 years, it rose to almost 85%. The MMR also, the maternal mortality ratios also, which were as high as 300, they also went down to 115 almost in the next 12 to 13 years, almost in 2018, I would say. But then there are studies to show that this decrease was rather very slow, and it cannot be attributed to the Janani Suraksha Yojana alone. So this is basically, we are trying to show that the maternal mortality ratios also went down and the number of institutional deliveries increased. But there are some buts in this Janani Suraksha Yojana. I would say that in a hurry to increase the number of institutional deliveries to happen, and usually mostly they were being performed by the so-called skilled birth attendants. So one trivialized the interventions which were happening. One trivialized the interventions, and also one cut down on the quality of the program. In fact, I would say in my state itself, 25% of the deliveries were happening in the sub-health centers, being managed by a single auxiliary midwife nurse, and there is no physician available. There is no vehicle which is parked 24/7 in case any obstetric emergency arises, which requires an immediate referral to a tertiary center. There is no blood storage units for immediate requirement of blood, and neither there is any operative facilities available for such women. So I would, and the second thing is the number of deliveries which were happening on the way also increased because there was shortage of facility, there was shortage of transport. We did try to increase or upgrade the skills of the medical officers who were placed in these tertiary institutional birthing stations, but one tried to give them training for doing cesarean sections and also for giving life-saving anesthesia. But then again, one was not able to ensure its uptake, and as a result of which there was no decline in the MMR. In Chhattisgarh, I would say there are around 130 such peripheral FRUs, as we call them. But if you ask me, in only 1 or 2 of the FRUs, cesareans are done, and that too also electively only. It is no emergency cesarean sections are done. So one does realize that until and unless we ensure a concurrent improvements in the quality of the interventions, mere access to a birthing institution cannot help in bringing down the MMRs as expected, as we want, I would say. We need to become quality-centric. If we want that these institutional birthing stations should work, we have to define a minimum criteria for an institution to be for an institution to be called as a birthing station. One has to define a minimum criteria. And then after that, one has to make sure and seriously work on it and ensure that there is skilled human resources, there are good infrastructure, and there is a continuous supplies. Sorry. The next thing which I think is I feel, because I have been working in a rural area for a very long time, is that in a hurry, in an attempt to develop the institutional birthing programs, we decided to ostracize and we decided to discourage the role of the traditional birth attendants, or whom in the local language we call them as dais. If you ask me, if any rural woman who is pregnant and she goes into the labor in the midnight or at some odd hours, the dai is the only lady who is readily available at that time to help her out. But in this in the program of Janani Suraksha Yojana, we decided that we will not support them. I feel, if you ask me, that along with developing the institutional or the birthing stations, we could have also taken the help of these dais or the traditional birth attendants so that they could accompany the rural woman to the hospital. They could be a companion to them in the process of delivery and also of their help. And we could have used their skills in the postpartum period, which is equally important in bringing down the MMR. So I think by discouraging or by ridiculing them, it is a big failure on our part. We should have used their skills. A conditional cash transfer. If you see, why I call it conditional is because the woman has, a rural woman has to have a bank account, only then this small amount of 1400 rupees. There are studies to show that the actual amount of money which is spent in the process of childbirth is much more, even if the whole expenditure is being borne by the birthing center. Still, one needs more money for it, for transport, for any emergency expenditures. So by offering a small, a meager amount of 1400, I would say that we are making fun of the poverty and dignity of a poor woman who comes to deliver and comes for support to these centers. These centers should have been fully equipped, and obviously the amount which is offered to such women should have been much larger than what it is given. So this, I think, is another failure of offering such a small amount to the women who deliver in these ill-equipped institutions, if you ask me. The Janani Suraksha Yojana, now we have put all the blame that we are not able to improve the quality parameters, and because of one is not able to do that, that is why the Janani Suraksha Yojana is not working well. But there is another parameter of JSY which is not often recognized or acknowledged, and that is of inequity. Inequity in the terms of the social, the economical, and the geographical determinants of the pregnant woman. As we can see from this, there are still 114 districts out of the total 640 districts which have an MMR of more than 220. And out of these 46 districts which have a very high MMR, they are situated in central India. This chart shows map is trying to show the distribution of the MMR, and as we can see, the central and the northeastern parts of our country still have a very high maternal mortality ratios. So I would say there is still inequity of this JSY program in terms of these determinants. So it is a failure if you ask. If a pregnant woman is poor, she lives in the rural areas, she belongs to a marginalized social group, or if she lives even in central or in the eastern parts of our country, there are high chances that she will die, as compared to a woman maybe like me who is urban, who is educated, who is not so poor and does not belong to an Adivasi or a rural family. So this program, JSY program, it has its successes because the MMR has gone down, but then it is not equal, it is not fair to all the pregnant women. It has its inequities. What needs to be done, which we strongly feel, is that one first has to acknowledge that there are so many determinants which are affecting the MMR, and also which includes the social, the geographical, as well as the economic conditions, and also the poorer districts. One has to acknowledge the poor quality of the interventions, and then one has to work strongly and focus more on the poorer districts, or the districts which are situated, which are marginalized and which have got a higher MMR. We have to focus more on those districts and then do it. Thank you.
Thank you so much, Rachna ji, for really kind of contextualizing a problem and how something can be perceived as a success or a failure based on several factors of geography, people, institutional capacity. Now I'd request Rajani ma'am to please have her presentation, where you also present another view, primarily giving us an insight again into MMR, IMR, and that aspect of health.
Thank you very much. Good morning, everybody. And a big thank you to the SELCO Foundation for inviting me to participate in this session. It's actually afforded me a little bit of luxury on reflecting on what it means to have a quote-unquote successful program to provide home-based newborn care to India's newborns, but identifying failures which may have deterred this successful program in reaching its true outcomes. So just for a little bit of orientation for those who are not perhaps from public health, is that newborn care in India is, or globally, refers to newborn deaths or neonatal mortality is deaths that occurred within the first month of life. 2/5 of all deaths of children under 5 are in this period, and 75% of them are preventable. And home-based newborn care was a pilot initiated in, okay, here, let me go on to the next one. Ashas, by the way, are community health workers in India at the level of every 1,000 population in rural areas, roughly, normatively at least, and 2,500 in urban areas. We have over 1 million Ashas in the country now. They were also introduced, and Rachna already talked to you about this National Rural Health Mission, which started in 2005. So India's Asha program also began then. The story I'm going to narrate starts actually in 1993 with a pilot program that was implemented by an NGO called Search in Gadchiroli in Maharashtra, where they did a trial in 39 villages using community health workers to provide care for mothers and newborn in their homes. At that time in Gadchiroli, 95% of deliveries did occur at home, and so DIs were undertaking the deliveries, and these specially trained community health workers undertook newborn care. And I'll describe to you a little bit about the component of that intervention that was undertaken in Gadchiroli. They succeeded in a decadal period, in 10 years, bringing the neonatal mortality down from 62 to 25. They did a second stage pilot in Maharashtra with similar community-based organizations and demonstrated a 51% decline, even though they were not directly managing the program. Then from 2005 to 2009, they worked with the Ministries of Health and Family Welfare and the Ministry of Women and Child Development in 5 states in India, where there were 3 arms of a trial. In one arm, Anganwadi workers, who are in charge of the Integrated Child Development Scheme that looks after 0 to 6 children, were entrusted with the responsibility of newborn care. In one arm, community health workers, similar to what had been used in the original trial, were used, and in one arm, the system functioned as it did. And here we saw 25% reductions only in the arm where community health workers specially trained for newborn care were used. In 2011, because by then we had the ASHA and the National Health Program, home-based newborn care became a part of the National ASHA program, so to speak. Now, 3 rounds of the National Family Health Survey demonstrated. So in 2005, when NRHM was launched, the NMR in India was 44. In 2015-16, it came down to 30, and in the latest round of NFHS, it's about 25. Now, not all of these declines are attributable directly to the ASHA, unlike in the original pilot, where because there were very few other interventions other than high and very robust referral systems to a healthcare facility, very little of it was similar to the pilot. So my objective in the next few minutes is going to share with you the challenges of scaling up a pilot intervention from a well-run, well-managed NGO program in a few villages to a national program, and then having managed the introduction of the scaling up, how do you sustain the scaling up? And therein lie the failure lessons. So the situation of newborn care in India, and I thank Rachna for having covered some of this. NMR in India was 44. 60% of infant mortality was contributed to by these newborn deaths. The critical period in the life of a newborn is the first day, then the first week, and then the first month. At that time, we had very low rates of institutional delivery, and even where there were institutional deliveries, mothers and newborns came home in less than 24 hours, and therefore the care that could have been available to them in a facility was not available. And referral was often unobtainable. The realization that high proportion of newborn deaths are preventable, and reducing, and so the policy of the National Health Mission at that time included these following components, saying that NMR in high mortality settings with weak health systems, and many of the same states that Rachna showed you, could be undertaken with robust community outreach, the provision of home-based care, supporting mothers and caregivers to improve home care practices, and ensuring access to hospital-based care. Now, it just looks like 4 components, but extremely complex. Each one of these components is an extremely complex intervention. So this was the Gadchiroli pilot. They had women community health workers. They undertook modular training for antenatal delivery care, care of normal and sick newborn. These workers were trained for 31 days over a year's period and interspersed by learning on the field, so to speak. They undertook a series of home visits from birth to 6 weeks to the houses of the newborns, and because they belonged to the same villages where the newborns were, they could do this much more frequently beyond the necessitated series of the prescribed home visits. Community health education, the workers of Gadchiroli were authorized to use injections and provide oral antibiotics as well as give injectable antibiotics, and they could use bag and mask for managing asphyxia, which is actually a very common cause of death in the newborn. There were fortnightly supervision, regular supplies given to the workers, performance-based payments, evaluation of knowledge and skills, and very robust on-the-job mentoring. This was undertaken in 39 villages. Moving to scale, when it was scaled up in the government health system, we had 1 million Ashas at that time, 800,000 I think. The model had to be simplified. So we dropped the injection and the bag and mask component, although some states like Jharkhand opted to keep the bag and mask component, very wisely recognizing that because they did not have the facilities in place to take care of newborn care, perhaps the Asha was the only recourse, and they had very high home deliveries at that time too. We reduced the number of training days. So this is a casualty of scale, if you like, the luxury of training. So we had 20 days covering a whole gamut of interventions to be delivered in a period of 1 year. And I can confidently say that many states, most states in fact, did not achieve this in 1 year. They took over 3 years, and we actually have some states who haven't yet completed that original 20 days of training. Then home-based newborn care was, of course, added to Asha training. The Asha was just meant to be a link worker. With the addition of this training, she actually got some skills in managing a newborn, added an equipment kit to the Asha. And when I say this, I think some realization, and many of you work with governments, must consider what an enormous task it is to procure the equipment and make sure it reaches every Asha in the village. So adding an equipment kit is just 4 words, but behind that lies a huge, huge set of activities which includes procurement, costing, deliveries, logistics. It's a whole, especially to get to that last mile Asha. Introduction of a supervisory cadre, and we're very grateful because it allowed us to advocate with the government to say, if you want the results that you saw in Gadchiroli, unless you have on-the-job mentoring by a facilitator who supports the Asha, you're not going to get those results. We never did get them, but still. Collaboration with search to sustain the spirit of the intervention and ensure fidelity to training. Again, a humongous task. Most state governments resisted the idea of sending their trainers all the way to Gadchiroli to be trained, but we insisted on it, and we were able to get this. And this made a huge difference to the way that at least the cadre of state trainers who were able to go back and train the next cadre of trainers in the field, because we do cascade training. And commensurately, there was also an expansion of newborn care corners, sick-born care, newborn units in healthcare facilities. This is needed. Not all newborns can be managed at home. Many of them do need referrals. Now, what were the major points of negotiation? I'm only talking about scaling from Gadchiroli to the National Health Program. We got a lot of pushback. Oh, how will we train so many Ashas? We don't have the training infrastructure to do it. Our existing supervisory mechanisms are already overstretched, and therefore we said, well, then let's get in new supervisory cadres, and we were able to be successful in that. We got 1 facilitator for every 20 Ashas. Orissa, Jharkhand all have 1 facilitator at the rate of 10 Ashas, which is much better. There were concerns over creating new mechanisms for training, because we insisted on moving training to the sub-block levels so that Ashas would be able to come. And we also insisted on residential training because it builds a sense of solidarity among community health workers to be trained together. There was a lot of pushback from doctors, of course. Professional privilege, you're handing over this equipment to the kit. Har Asha ko doctor banaoge kya? This was a common refrain. We also had competing priorities. WHO, UNICEF had a model of integrated management of newborn and childhood management. Now that didn't entail so many skills, and therefore that model was being pushed, and there was this constant comparison about they're doing this and the government is proposing this, what do you really want? Civil society also pushed back. They said the role of the Asha was an activist mobilizer. Now you're converting her into a care provider, and therefore you're going to give poor care to poor communities. It was another big challenge. And then we had this maternity entitlements for institutional delivery and 48-hour stay. And so people said, so why do you want newborn care? Anyway, the first 2 days, first day and first week are the tough ones. We'll take care of the first day by giving JSY to all mothers, and you heard from Rachna how that panned out. All right. So the lessons for scaling up, and some of it I've already covered, so I won't go beyond this. So, you know, we all talk about evidence-based scaling up. It actually extends much beyond evidence. We had the evidence. We had Gadchiroli that showed us 62% reduction. We had 25% reduction even in government-run community health worker programs to address newborn care. But it needed much more than that. It needs contestation, negotiation, and extensive consultations. And I've written here before and during adoption, I think it needs to continue for as long as the program sustains. It cannot end at any one point. Assessing system readiness, I think there was a bit of a hurry there, and there's always this trade-off, you know, is the system ready? Can we introduce this and then get the system ready? How do you decide? It depends on context. It's messy and iterative. Large-scale implementation implies quality loss. This is something we've seen over and over again, something that NGOs can pilot at scale in government. You must be prepared for quality loss, and then figure out how to address that quality loss. Balancing the pressures of quick scale-up. Within 1 year of starting the program, how has neonatal mortality not reduced? We are investing so much in ASHA training, you haven't reduced neonatal mortality. Persistent advocacy, systematic scaling up. Now that was a lesson. Developing standardized protocols, modules, having training programs that were structured in place, criteria for selection of trainers, all that does go a long way towards scaling up a program. And then having an intermediary agency in place. Search was one intermediary agency, the National Health Systems Resource Center, and in the states, we had state health systems resource centers in many states that helped this partnership and knowledge management and sustained the program on the ground. My final slide. So we started the program in 2011. A decade later, what is the outcome of home-based? You saw the data. It's at 25, from 44 to 25 in a 17-year period. One might say, and this varies across states. India has so much diversity, so it'll vary. And Rachna showed you those maps. The same one would reflect same for neonatal mortality. There's widely varying coverage of home-based newborn care. In Chhattisgarh, for instance, which has a very robust ASHA program, 75% of ASHAs actually do the 6 visits that are mandated in the first 4 weeks. And therefore, but in Haryana, it's only 15%. In Uttar Pradesh, it's about 32%. 32% of ASHAs undertake 1 visit, not the entire 6 weeks, because they are paid an incentive for 3 visits out of the 6, because, you know, it became very onerous to track the visits, and at that time we didn't have technology. Maybe now it'll get better. Coverage and quality linked to the support provided to the ASHA. That's why states like Odisha, Jharkhand, and Chhattisgarh do much better than UP, MP, and Bihar. There's an equation of the incentive dispersal. So at the national or the state level, they calculate the 250 rupees that's paid to every ASHA and divide it by the number of ASHAs and say, okay, this is the coverage of home-based newborn care, which is actually a terrible way of doing it. But because it's to say that we are covering so many newborns with home-based newborn care, but that's not the real truth. And that actually limits contextual investigation at the district and the sub-district levels, because everybody is so comfortable with the amounts being disbursed to the ASHA. And rightfully so, the ASHA deserves that money. Post-discharge follow-up notification. Now, as the expansion of facility-based newborn care increased, we had more babies going up to referral. But when they came back home, that notification to the ASHA that here's a sick baby that you sent or came from your village is coming back and still needs care is very, very low. And that is a huge missed opportunity. Whereas in a small setting, it's easy to do that. At the scale setting that we have in districts and sub-districts, it's difficult to do, and that's not happening. We have high institutional deliveries, but very weak intrapartum care quality, as Rachna pointed out. Limited training in organizing home visits. And this is linked to my last point about, since the program began in 2005 with about 4 tasks that the ASHA had, today the ASHA has over 40 tasks to perform. ASHA doesn't complain because most of her tasks are linked to incentives, and she is very well prepared since she is there in the village and says to us that I'm a 24-hour worker. But the fact is that the number of tasks she's asked to undertake have grown enormously. And therefore, she's asked to go to the same home to look for a person over 30 years who may have risk factors related to non-communicable diseases, to follow up on lymphatic filariasis, to follow up on leprosy or on active tuberculosis case finding, and newborn and maternal care. And this idea of organizing her day into a structured visit has not yet percolated, and I think that's an area for us to work on. And by the way, none of these failures are things that can't be worked on, and that's why I had them both in quote unquote. I think that's all right, thank you.
Thank you so much, Rajani, and I think in a way this is kind of signifying the title of this session, which is Simplicities and Complexities of Health Facility, Health or Public Health itself. Because you're thinking it's a very simple solution, but the scale of it, the institution behind it, the partners involved, the stakeholders involved, the capacity involved, it's not a simple issue at all. On our last speaker, I wanted to reflect a little bit more from a macro perspective. I think all of us here as development practitioners, one of the things we need to always strike a balance in is how do we cater to the needs today while making sure that it doesn't emerge as a need again in the future. We also almost always say that, as NGOs, the biggest indicator of us solving the problem is that we don't exist anymore. The civil society is not needed, either in its current form or as an entity itself. How do we really strike that balance for health? Where do the challenges lie? How do we go towards a factor that, or a world where going to the hospital is the last resort? If you could comment a little bit on that.
Yeah. No, I think it's a great question. Thank you very much for having me here. I'm somewhat of a poor fit in this August panel because I really don't have that much direct experience of public health. Most of my health work is new, and that's in curative health. I do work in public mental health now, but it's an early journey. So I'm grateful that I'm getting somewhat broader questions to respond to. Most of my work has been in the financial services arena. As Neeraj pointed out of 100 interventions, perhaps one succeeded, 99 were colossal failures. And indeed, I'm happy with the one, and that's something to be pleased about, but there were many, many things that didn't work out. But the benefit we have in finance is that in some ways, I mean, people could differ on this, and particularly now that this case is going on, the demonetization, it's not often a life and death matter. You can imagine a world. I chaired a committee for Reserve Bank of India when I was on their board on what the future of finance might look like, and then kind of work backwards from that to say, what should you do today that both helps today but works towards the future, even if sometimes you compromise the needs of today. In health, you don't have that luxury. You can imagine a world of the future, but people are living and dying today. And you can't say, well, I'll get to you later. Why don't we worry about the future and then work towards that problem? And clearly that's a challenge. As a novice in this field, somebody that's just trying to understand what the opportunities and challenges are, my sense is the underlying thought still remains. As to, and I like working backwards rather than working forwards and viewing today as a constraint against which you try to maximize. And to give you one specific example, I was in a workshop that, Path also sent somebody that was trying to look at can systems modeling, complex adaptive systems modeling be used in health systems design. And an interesting issue came up in that conversation, that of time horizon. If we looked at 2025 or 2030, curative health was very important because you really needed to figure out many of the issues that were raised very nicely, babies delivered, babies dying, hospitals, this, that, and the other. But if you look 2050, curative health fell away in importance because really now we were talking about not so much when the system failed and you fell sick, what to do, how can we maximize the possibility that you don't fall sick in the first place? Just to give you a narrow example of something like this, in tuberculosis, we know, many of us in this room, about half the population has latent tuberculosis. And the key concern in the here and now is how do I treat somebody who's got tuberculosis? In part because I've got to take care of them, in part if I don't do it, they will develop multi-drug resistant tuberculosis, XDR TB, and it will become, a significant problem. But as I think longer, the question to ask is, how can I make sure latent TB doesn't turn into active TB? And that has got a lot to do with the building codes that cities are implementing to get ventilation. There is a very nice study that came out of Bombay that showed that these new buildings, that were built since 2007 of the Slum Rehabilitation Act, in places like Govandi, I don't know if you know Bombay at all, some of the remote slums, where slum areas were being cleared, they were being given housing so that high rises for middle income, upper income populations could be built. And the economics was working out very well, but the SRA buildings, as they were called, didn't follow a 100-year rule which gave people enough light and air. The study showed that the first floor TB burden in those buildings was 10 times higher than the TB burden on the 10th floor of the same building because of the changes in light and air availability by level. So as you think longer term, curative systems start to become far less important, and public health or social determinants, One Health, many of these issues that are becoming much more important now start to become far more salient.
I think one time we were having a discussion on livelihood, and there was a panelist who kept talking about health. The moderator was just like, what's happening? And she was like, health is livelihood, livelihood is health. Right? And I think that's what you were referring to as well. Like once you start looking at it from a curative perspective, it becomes much more cross-cutting. Because you're talking about building codes, you're talking about maybe the smoke that they're inhaling while they're actually cooking or actually in their livelihoods itself. Mental health is something that you had spoken about when we spoken about earlier as well. But I mean, silo thinking is very natural to all of us. And I'm saying as humans, as entities, that's how we are structured. But the way that you're talking, it has to, we have to break that boundary. And again, it's not just for health, it's for livelihood as well. It's for other discussions that we've been having. Could you share with us some learnings that we can all take back on either how can we break that silo thinking, or if we are trying to design programs which converge programs and ideas and sectors together, what should we keep in mind? What are the points of failures? What are the weakest links in that sense?
I mean, obviously, if I knew answers to this, I would be standing in line for the Nobel Prize. But, indeed, these are complex questions, and I don't claim to have any very deep answers to this. The issue is very much there, though. For example, one of the areas in which I'm working in is urban health. Right? And we have the sense that pollution matters. Well, in an abstract sense, it does. But unfortunately, what you find with the evidence on the ground, clean stoves, you can't find the impact on respiratory disease. As pollution levels go up, you see the dose response. As pollution levels go down, you don't see it. If you see ambient air, we know that ambient air, many respiratory diseases come up. But unfortunately, the curve, once you cross the safety limit of PM 2.5, flattens. So what happens is that if you have very high PM 2.5 and you bring it down a little bit, it has no mortality impact. You have to really bring it to near zero in order to show mortality impact. A city like Delhi may say, well, we can't bring it to zero. Maybe then we should not try, because it's not an area of big attention. So that's kind of where things are not working. But there's other opportunities in which things could work. Bangalore, for example, emphasizes a lot green spaces. And people feel that's the right thing to do in order to give play, in order to give green lungs, as it were. But it turns out the evidence suggests that actually these things are a waste of money. The thing that produces the 30 minutes a day of active, what you need in terms of exercise, clean pavements in the city actually are far more effective at doing that than smaller areas that you have created elsewhere. There's hardly any utilization. My lived experience in living in Bangalore in the last 3 years is consistent with that. Most parks, most times during the day, are empty, which is great for me. I can do a jog without encountering anybody, but I don't know if it's such a good use. And even for green spaces, what you find is that the green streets are far more important than parks. And even for play, because parks require adults to come with you, often children don't go to the park. It's play streets nearby, near your home. In fact, as it turns out, the poor get a lot more play, the very rich get a lot more play. It's the middle income that don't get much play, because there's no space at all near their street, and they can't really get much activity. So you're quite right that we have to think across many of these. But the way I see it, I'm working on a new paper for, at the request of one of the government departments, on thinking about how does one organize for One Health, right? And the word One Health seems to suggest you bring everybody together, everybody needs to collaborate. So I looked at multiple country experiences as trying to set up these One Health structures, governance structures. Consistent failure. The coordination that we imagine should happen just does not happen. Right? And an economist in me is then looking for what we call separating hyperplanes, which is there a way we can use mechanisms, in some ways a middleware. In carbon, you've seen the price of carbon as an important, separating hyperplane, because now I don't need to coordinate. All I need to do is to measure how much carbon dioxide I'm producing and either pay or claim a subsidy. And the belief is that single price can make it work. What in One Health we are trying to do, in my paper, what I'm trying to suggest is maybe we may need to acknowledge to say that we need to think carefully as researchers and academics and propose to governments separating hyperplanes. For example, we know that urban areas, because of sewerage issues, you see a lot more diseases which are rickettsial and protozoal. Right? Maybe what we need to think about is not to burden Ministry of Health with all of One Health, but to say Ministry of Urban Affairs, municipalities, focus on protozoal and rickettsial diseases. Because that's what you can do. Rats and the ticks on the rats are the big issue. Focus on that. Right? Maybe coronavirus was a problem, but it's the travel industry that really transmitted it. But neither the railways, nor the airlines, nor commerce had any idea what to do. They do have health departments, but everybody was waiting for health ministry to say what to do. Right? Maybe they are not well equipped to do that. Right? So one way to deal with coordination is to explicitly recognize that coordination is going to fail upfront, not imagine that there will be a coordination, and then design for that. So that you can think about not having coordination as not necessarily a problem, but a design problem around which you try to address it. I don't know if this will work or not. Mine is an academic paper. It's not yet published, so the reviewers might reject it also. But, maybe there's something there.
We know now. Thank you so much, Nachiket, and can we have a round of applause, please? So I really apologize. I have my eye on the clock, even as an organizer as well as a moderator. I know there are extremely interesting questions in Slido, and please reach out to any of our panelists, to follow up on these super interesting conversations. I feel like I don't have to summarize, but generally I feel like, when we, as I said, like a lot of the times when we speak, we say, livelihood is complex because crop changes from place to place, business models change place to place, market changes place to place. But health, it's one human body. So we can actually design systems very easily, and we can actually have, one disease, one medicine. But as we heard from everyone, it's not so easy because scale and the problem at scale has its own challenges as well. There are still complexities that we heard from our panelists, which were around economics of projects, social determinants being a barrier, the capacity of the system that not many of us account for, people's behavior, convergence of problems, but more importantly, stakeholders and ideologies, as well as, sometimes just us not having the larger sight in mind. So I think all of us, when we're designing programs, I don't know if any of us keep these points as in our minds at all, as factors that we need to consider, as Nachiket pointed out. So I hope as one takeaway, we're able to take that forward. And once again, a big round of applause, please, for the panelists here. Thank you so much to all of you.